I'm Dr. C Gupta, Clinical Director and Chief of Vascular Surgery. We have a very unique department in CARE hospitals. It combines vascular and endovascular surgery with interventional radiology. And here is Dr. Pradeep, my colleague. He's the Director of Interventional Radiology in our department. We also combine podiatric surgery, which deals with foot problems, and of course, clinical psychology. So these are things that we'll discuss later. Today we are going to discuss a very interesting subject. We are seeing more and more patients who are diabetic, as a result of which we are seeing more and more patients who are developing kidney problems and going on to dialysis. Now, earlier when a patient developed kidney failure and went on to dialysis, dialysis was considered virtually to be the death warrant for that patient. But over the years, things have changed a lot. And now we have patients who are on dialysis for 5 years, 10 years, 15 years, and we have patients who are on dialysis for even 20 years. Now, the best way to dialyze a patient is using an AV fistula, considered the lifeline of a patient who has kidney failure. Now, like any other system, I'm sure AV fistulas develop problems. Is that right, Dr. Pradeep?
That's true.
For example, we have the plumbing system in the house, we have the electrical system in the house. There is wear and tear. And over the years, all these things require maintenance. Similarly, an AV fistula, which is being used for dialysis repeatedly 3 or 4 times a week, will require maintenance. So, Dr. Pradeep, what do you think are the common problems that we see in patients who have long-standing or even, let's say, short-standing fistulas and they seem to malfunction?
I think as you just mentioned, fistula is a lifeline. So generally when we talk to the patients, we tell them it is like a heart. If this doesn't function, then you have problems with it. So problems generally we see is what we call as a dysfunctioning fistula. That means the fistula which is supposed to be used for dialysis is not doing its job. That means you are not having good clearance at the time of dialysis, where patients are not clearing their the potassium, sodium, creatinine, urea at the time of dialysis.
So what are the problems in that fistula which is causing this? I mean, are there some blockages or are there some other problems in the vein or the artery which result in this?
Yeah. Because AV fistula is an artificial connection between the artery and the vein, and vein is not used to having that high flows. So when you have that, then it is very common to get narrowing in the veins. And whenever we get narrowings, whether it can get clots or complete blockage, which results in the non-functioning or dysfunctioning of the fistula.
Yeah. So one of the things one of my colleagues was telling me, of course, one of the places where the veins get narrowed are the puncture sites, where the needles are put into the fistula to dialyze the patient because of repeated injury. The other place where the veins get damaged is wherever they bend.
True.
For example, the other day my colleague Dr. Rahul was saying, it's like a high-speed highway in the vein. So if you're on a high-speed highway and there is an acute turn, and if you keep going fast, you're going to hit that bend and have an accident. But if you slow down, then you can go smoothly. But here the blood doesn't know that it has to slow down. So the blood continues to go fast into what is supposed to be a low pressure system. And the vein gets damaged and becomes narrow. What we have seen is that over the years, endovascular or interventional procedures have changed the outlook for patients on hemodialysis. We can make these fistulas work longer and longer. Would you agree with that, Dr. Pradeep?
Yes, I think I would probably say in last 18 to 20 years, we are trying to make the existing fistula function as long as possible. Even if it involves doing some repeat procedures once or twice a year, because we as people who operate on them regularly, there are limited options for the fistulas. You can call it 4 options or 6 options depending on the patient's body habitus. So the whole idea is to make the fistula function as long as possible, even if it requires some repeat procedures.
So if there is a narrowing in the fistula, what is the typical procedure that you perform on such a patient?
So whenever we have a narrowing, first of all I want to say that most of these procedures are fairly simple and performed as daycare procedures. And whenever there is a narrowing, the commonest thing that we do is putting a balloon and dilating the narrow part, so that the blood which was flowing through with difficulty now flows freely, so that the dialysis, the quality of dialysis is better. And sometimes patients have pain during the dialysis. Again, that may be due to the narrowings in the vein. So we can alleviate some of their symptoms.
Yeah. So this is just like an angioplasty, which is done in the peripheral arteries, which is also done in the heart, in the coronary arteries. So when we do this angioplasty in fistulas, we call it fistuloplasty. But it's very similar to angioplasty with a balloon. Do we commonly place stents after we do fistuloplasty or angioplasty like in the heart?
Yeah, I think it's a very interesting question, because whenever we talk about bypass and angioplasty, most of the people think that bypass is something to do with the heart and angioplasty is something to do with the heart, where they place stents. Unlike in heart, here we rarely use stents, because these are the areas where the technicians, when they do dialysis, they put needles. So we avoid where the needles are put. Very rarely in somewhere close to the neck. Sometimes in patients we do stents, and again if they have central vein problems in the chest, we can look at the stents as a kind of bailout options, not as a primary choice.
So do you think these procedures like fistuloplasty or angioplasty, which are minimally invasive, do they provide an advantage over standard open surgery?
I think both have the role. And if there is a narrowing very close to the anastomosis, that is where the artery and vein is joined, and if it is amenable for surgery, then doing a revision fistula is usually gives a long-term better results. Whereas if you have narrowings in the multiple locations in the veins, just like how you mentioned in the needling sites, so there we can't do surgery for the entire vein. That is where the endovascular procedures have a role. And definitely these are repeat procedures, and even if sometimes we do open surgery, at the site of surgery again we may get narrowing. So as long as we have this open discussion with the patients, telling them the pros and cons, we can choose the right procedure for the patient.
So what I get is that it's important for the patient and the family to understand that it is not a one-time procedure.
Absolutely.
This is a problem that can recur and will require repeat procedures.
True.
But by repeating these procedures, we can prolong the life of a fistula.
True.
So do you think it is important to detect and fix these problems early? Or can a patient sort of wait till the fistula is really giving a lot of trouble and then come for the procedure?
I think over the periods what we have understood is screening these patients and picking up the problems early will save a lot of effort, time and money for the patients. So that's why we believe very strongly in stringent follow-up of these patients, so that we pick up the problems early, and that can be dealt with lesser invasive procedures. Otherwise, when they come with a completely blocked fistula, when compared to simple narrowing, then the whole procedure changes, and the pain, the duration of the surgery, outcomes, all these things matter. So I strongly believe that screening of the patients, following up the patients after fistula, even after fistuloplasty or balloon angioplasty, is a must, and that we follow regularly in our clinical practice.
Yeah, I think we are one of the very few units which has a dedicated surveillance program for AV fistulas, so that once a fistula is made, we periodically call these patients for evaluation to see that the fistula is functioning well, and if there is a problem which we can pick up and can fix, we would offer that to the patient.
Yes.
And once we do a procedure like a fistuloplasty, then we call these patients more often, and depending on how it pans out, whether the fistula is sort of narrowing again or not narrowing again, we keep them under regular follow-up to pick up a problem as soon as it occurs. We also inform the dialysis technicians
Yes.
as to what are the signs that the fistula may be having trouble, so that they can guide the patients to visit
Yeah, I think
a vascular team.
So most of the times it happens so that technicians themselves will tell, okay, the flows have come down now. Maybe this is the time for you to go and visit them because you already had one balloon. Maybe they want to repeat that procedure again. The common thing, like most of the times we tell the patients, education here is this is a repeat procedure. So please be mentally prepared for it. It is not like a one-off procedure. Otherwise, disappointment among the patients is like, why am I having so many procedures? But repeated talking to them, counseling them, then we gain their confidence.
So if there is one message you would like to convey to these patients to maintain their fistulas for a long time, what would you say?
I think surgery is only the beginning, follow-up is a must.
Yeah. So I think, Dr. Pradeep, you would agree with me that endovascular interventions for problems related to AV fistulas have really transformed the care that we can provide to these patients and make these fistulas last longer and longer, so that patients can continue and maintain a good quality of life for a much longer period than they were doing earlier.
Absolutely, absolutely. I mean, there is no doubt. As far as me personally is concerned, what I have seen is the change of landscape of dialysis access maintenance has seen a huge change since locally when we start offering the services. I think the patient education and outcomes have definitely changed.
Thank you, Dr. Pradeep.